And then before you start, it would be great if you can count out loud until 5, and then you can just start whenever you're ready.
1, 2, 3, 4, 5. How is that?
You can go ahead and start.
So thank you. So anyway, so can we count to 3, then we get started?
3, 2, 1.
Greetings from the Africa Centers for Disease Control and Prevention, which is a specialized technical institution of the African Union based in Addis Ababa, Ethiopia. It is an honor for me to speak at this very important conference on interest, and also an honor to have been asked to give the Charles Boucher's Memorial Lecture, which will be focusing on the epidemiological trends of HIV in Africa. First of all, in memory of Charles, that we all know, Charles was a great friend, a great colleague, and a great scientist. He was a clinician, a microbiologist who founded the Virology Education, a company organizing international workshops and conferences and medical education in virology worldwide. He was a pioneer in doing HIV research. And I personally know Charles a long time ago when I was in graduate school at the Institute of Tropical Medicine. And we used to follow very closely his works and those of other Dutch scientists in the areas of HIV/AIDS pathogenesis, including the studies on syncytia-inducing viruses, antimicrobial resistance, and others. As a continent, this graph shows you a summary of HIV/AIDS pandemic in the world. I will not go through all these numbers, but suffice to say that a total of 37.7 million people are currently living with HIV/AIDS. And there are about 1.5 million people that are newly infected or were newly infected in 2020. About 680,000 AIDS-related deaths occurred in 2020. We hope to update these numbers by December 1st, when new numbers will be shared by the UNAIDS. Every day, there are about 4,000 new HIV infections. That includes adults and children in Africa. That is in 2020. And Africa, as we all know, carries the burden of HIV/AIDS, where 60% of the infections are in sub-Saharan Africa. 10% are among children under 15 years old, and 90% are among adults aged 15 years and older, of whom 51% are among women, 31% amongst young people, and 20% amongst young women. This graph shows you the HIV distribution, HIV/AIDS distribution by region. If you look at the graph on your, the bar on your left-hand side, it shows you the adults and children living with HIV/AIDS. And the blue bars are those adults and children newly infected with HIV/AIDS, and the orange bars are adults and children deaths due to HIV/AIDS. Clearly seen that the East and Southern African region carry the burden of this infection in Africa, followed by West and Central Africa, and the Middle East and the Middle or Northern Africa is the least affected region. This graph shows you the adults and children estimated to be living with HIV/AIDS between 1990 and 2020. Of course, the graph you see here shows the adults and children estimate with a range of uncertainty around it, but clearly showing that there have been, of course, a cumulative increase over the years. The picture on your right-hand side shows you the people living with HIV/AIDS by region between 1990 and 2020. And the different colors represent the different regions of the continent. We clearly, you can see the orange line there represents the Southern African region, followed by East Africa and Central and West Africa. The numbers are on your left-hand side by region, indicating where the most burden is. If you translate those numbers, the cumulative numbers of 37.7 million people, you see that 20.6 million are from Eastern and Southern Africa, 4.7 million in West and Central Africa, and 230,000 in the Middle East and North Africa region. Clearly, the message on this slide is the disproportionate impact of HIV/AIDS in the Southern and Eastern African part of the continent. This graph shows you the number of adults and children newly infected between 1990 and 2020. Adults and children newly infected represent the green line, and of course the range of uncertainty is provided. We'll call it a confidence interval. And if we unpack that a little bit further, again, we see the same thing, where if I just ask you to focus on the right-hand side, you see the Southern and Eastern African countries are the most impacted area. And the graph on your left-hand side shows you the number of infections by regions, the absolute number by regions. This graph shows you the adult and children deaths due to AIDS between 1990 and 2000, clearly showing a trend. And it's remarkable that I ask that you look at 2005 time frame. Very important period, because that is antiretroviral therapy had actually been scaled up thanks to the efforts of different partnerships, including the Global Fund, PEPFAR, and other initiatives that became a game changer in bending the curve of mortality amongst both adults and children suffering from HIV/AIDS. And if you break that down also carefully, you see this also by region, clearly showing that between the year 2000 and 2004, where ARVs were introduced, they had a dramatic impact on the death rates across all regions of the continent. This graph shows you the 40 years of AIDS response. I will not go into describing everything on this curve because it's pretty busy, but suffice to say, to point you to some key milestones. In 1980, where HIV/AIDS was first described, in 1981, where the official report of what would become HIV pandemic were published, and fast forward, and very importantly, when the African Union committed in 2000 and committed to allocate at least 15% of annual budget to improve the health sector. I emphasize this because that target still needs to be met, and it is important, especially now in the context of COVID-19 pandemic, that these targets are achieved. We don't need new declarations to achieve this, but it is assumed that they will, member states will rally around and commit themselves to these goals. This graph shows you very clearly amongst people living with HIV, the percentage who know their status, the HIV positive status, and are receiving treatment and are virally suppressed. Let's start with the graph on your left-hand side. It shows the people who know their status, and about 84% of the population, people receiving ARTs, about 73%, and people with suppressed viremia, about 66%. And if you look at that, you unpack it by men and women, you look at the graph now on your right-hand side, people who know their status, again, men by sex, and clearly a slight difference there by sex, because many women, both in the treatment and with viral suppression, pointing to the fact that there's a lot of work to be done amongst men above 15 years old, so that they can actually know their status, receive their treatment, and have viral suppression. So I showed you earlier the graph with the ARTs, the magic that ARTs have performed. This graph now shows you the coverage by region, by the five geographic regions of the continent. And clearly also again highlighting the limitations that we encounter with some parts of the region, with again East Africa and Southern Africa having the most coverage and other parts of the region not having appropriate coverage of ART, with just about 61% and 68% in some parts of the continent. This graph shows you the percentage of people living with HIV receiving ARV treatment by different regions of Africa. Very clearly, there's been a systematic or steady increase over the years, but again, in some parts of the continent, like West Africa and Central Africa, a lot of work needs to still be done there. So now let's focus on the targets that were initially set up to end HIV/AIDS pandemic by the year 2030. And these targets they all came to be known like 90-90-90. That is 90% of people will know their status, 90% of the people will start treatment, and 90% of the people will have viral suppression. And that has target, again, developed by UNAIDS, has been determinant in guiding all of us in achieving our targets. The countries reaching some of these targets are indicated here. Countries, especially in Southern Africa, have done remarkably well in achieving some of these targets, especially amongst women, not necessarily so amongst men, but overall, countries have moved with that target in the right direction. Now, if we look at the new strategy framework, that is the Global AIDS Strategy that spans between 2021 to 2026, developed by the UNAIDS, I think its vision is clear: zero discrimination, zero new HIV infections, and zero AIDS-related deaths. They're all targeted or aimed at ending AIDS as a public health threat by the year 2020. I would not go into this, the right-hand side of this, which speaks to the inequity lens that is guiding us across all of these strategic priorities there, but rather focus on the cross-cutting elements that are critical for us to achieve those targets, including strong leadership and country ownership and advocacy, partnerships, multi-sectoral nature of collaboration, data science and research and innovation, stigmatization, discrimination, human rights and gender equality, cities, urbanization, and human settlement are all cross-cutting things that are required if we have to achieve the strategic goals and priorities of the strategy. Let's look at this, the impact of COVID. What has COVID done to us? We published a paper in the proceedings of the PlusMed, I beg your pardon, last year, where we clearly reviewed the impact of COVID on HIV, which was anticipated. But this data, as you see here, indicates the percentage change in number of people initiating ART compared to baseline between January and February 2020 by month. I mean, you can clearly see that baseline, the baseline in January and February reports that the rates of testing have actually decreased significantly across the board in many countries as a result of the COVID-19 pandemic. This slide also shows you the tests conducted amongst HIV positive results, and the ability to retain those results have also been affected significantly because of the impact of COVID disruption. So let me now switch to HIV drug resistance, which is an area that Charles had a passion for. In 2019, an estimated 67% of people living with HIV/AIDS, living with HIV globally receive antiretroviral treatment. Up to 26% of people initiating treatment are infected with virus carrying resistance to first-line drugs, such as efavirenz. very high level of HIV drug resistance, up to 69%, are seen in infants born to mothers infected with HIV. These data emphasize the need to fast-track the transition to newer regimens, that is, drugs that will have higher barrier for drug resistance to occur. Some HIV medicines, such as those belonging to the NNRTI class or first-generation integrase inhibitors class, are more prone to drug resistance, while other drugs, such as dolutegravir, have a higher barrier to drug resistance due to the high level of resistance to NNRTIs and other considerations, including cost. WHO recommends that countries transition to these other regimens. So this graph again shows the picture of drug resistant, global drug resistant rates in ARV naive patients. And clearly, the more countries have used ART drugs, the more the drug resistance is expected to happen. And those countries that you see in gray are countries that clearly do not, probably have not expanded ARTs or have not documented HIV drug resistance based on proper studies. There's progress in transitioning to DTG as preferred first-line ART regimens in low and middle income countries. And you can see clearly that in Africa in particular, most countries are now using it as their first-line regimen. And at least 98% of low and medium income countries are using or are making shifts to DTG containing regimens. So what is the level of drug resistance against these drugs? Again, clearly, if you compare with the wild type, you can see that there's also going to be resistant as this drug is expanded and used across the board, as you can see on the different peaks on this slide. However, this mutation, what we call the point mutation, improved replication in presence of DTR, as you can see in this graph, especially on the right-hand side, showing the wild type virus replicating more efficiently, and the PP mutant replicates even more efficiently as well. So, and this graph shows you the mutations reduction effects on the DTG sensitivity across the board. So infections with the cells, this is in vitro assays that are conducted to measure phenotypic drug resistance against this important drug. So as I move to my conclusion, let me just reflect on the collaborative studies that or efforts that we had with Charles. You can see here that with Charles, we had started organizing the international conferences on emerging and re-emerging infectious diseases. And Charles and I, we used to be co-chairs, and other members that you can see on your right-hand side were organizing committee members. I really enjoyed working with Charles over the course of the period. We organized these very important conferences on emerging and re-emerging infectious diseases. When we were doing this, especially the last one in Addis Ababa between the 13th and 15th of March 2019, did we know that at the end of that year, the world would be completely overtaken by the COVID-19 pandemic. So Charles will forever be remembered as one of those heroes, infectious disease experts, and a strong collaborator. He collaborated with passion, with respect, and with vision. So forever at Africa CDC, continue to remember Charles in that lens. So again, Charles was an outstanding researcher who was a pioneer in doing HIV research. He was a reviewer for scientific journals, co-chair of several international committees, and author of numerous scientific publications. I thank you for the opportunity to deliver this lecture.